Good morning, everyone. Today's topic will be superficial fungal infection. So, the common cutaneous fungal infection will be divided into three categories, that is superficial, subcutaneous, and deep mycosis. Superficial fungal infections are due to the fungi that involve only the keratinized tissue, that is stratum corneum of the skin, hair, and nails. Whereas subcutaneous fungal infection will involve dermis and subcutaneous tissue, and then deep mycosis will involve other internal organs along with the skin. So again, the superficial mycosis is subdivided into inflammatory and non-inflammatory. Some cutaneous fungal infection will show minimal inflammation, that is Pityriasis versicolor, Tinea nigra, black piedra, white piedra, and some fungal infection which shows inflammatory response will be Tinea capitis, Tinea barbae, Tinea faciei, corporis, cruris, manuum, pedis, and cutaneous Candidiasis also. So each one of it will be discussed later in the class. So coming to the predisposing factors for acquiring this infection will be tropical climate, people working as manual laborers from the low socioeconomic status. All these above three factors will lead to profuse sweating. Once they sweat, the skin will become porous. That is how it will absorb whatever deposited on the skin, and in turn the fungal infection will evolve. Along with the above mentioned factors, there are other factors like friction with the clothes, wearing synthetic inner garments, malnourishment, immunosuppressed patients like HIV, diabetes, congenital immunodeficiencies, patients on systemic or oral corticosteroids, and immunosuppressive drugs. These predisposing factors are common for most of the fungal infections. Coming to the fungal infection in particular, that is Pityriasis versicolor. It is also known as Tinea versicolor. The etiological agent is Malassezia furfur. So clinically it presents mostly among the youth. It is presents as multiple discrete asymptomatic discolored macules. Some may be hyperpigmented or some may be hypopigmented. It starts with pinhead-sized macules and later coalesce to become large sheets of discoloration. It usually presents on the seborrheic areas, that is upper trunk, shoulders, and arms, less frequently on the face, even if it presents especially in children. Scalp, antecubital fossa, submammary region, and groin are the other less frequently affected areas. Inverse Pityriasis versicolor, it is, as the name suggests, it involves the flexural areas. Hypopigmentation is due to the inhibitory effects of the dicarboxylic acid on the melanocytes. On Wood's lamp examination, you will see yellow fluorescence of these macules or patches. So when you send these scrapings for KOH, it will show spaghetti and meatball appearance. That is, it shows coarse mycelium fragmented to short filaments of 2 to 5 micron wide and up to 2 to 5 micron long, together with spherical thick-walled ease measuring 2 to 8 microns in diameter, arranged in grape-like fashion. So these fragmented filaments are called as spaghetti, and these eased grape-like clusters are called as meatballs. So this is the pictorial description. The left side picture shows multiple hypopigmented macules, and few areas it shows coalescing patches. And the second picture is showing multiple filaments. Those are nothing but spaghetti, and multiple yeast cells, clusters like in cluster-like arrangement. Those are nothing but meatball appearance. So coming to dermatophytosis, This is the most commonest infection where you clinically see. These are the fungal infections that invade and multiply within the keratinized tissue of skin, hair, and nail. They are subdivided depending on the mode of transmission, that is anthrophilic. Mode of transmission will be from human to human. Clinically, it presents as mild to non-inflammatory chronic infection. The commonest etiological agent will be Trichophyton rubrum, Trichophyton tonsurans, and Trichophyton mentagrophytes. Second category will be zoophilic, that is animal to human transmission. It shows intense inflammation. It can present with pustules and vesicles and possible acute presentation. So the etiological agent will be Trichophyton mentagrophytes or mentagrophytes, Microsporum canis and Trichophyton verrucosum. Geophilic, this is transmission from soil to human or soil to animal. So this will present with moderate inflammation caused by Microsporum gypsum. Coming to the pathogenesis, once the predisposing factors the host is exposed to, so say if he is from a low socioeconomic background with the poor hygiene practices and manual labor, the skin will become porous on sweating. On contact with these fungal elements, it adheres to the stratum corneum and it will get penetrated through these pores. And then it is at keratinasis acts causing to the invasion of fungi into the stratum corneum. Releasing of proteases, inhibitors, beta globulins, mannins, inhibitive factors on sebum and ferritin. That is how the disease will manifest. Depending on the anatomical distribution, these are the terminologies used. If the dermatophytosis or layman term called as ringworm, if it presents on the head, that is scalp, it is called as Tinea capitis. It's on the face, it is Tinea faciei. Beard area is Tinea barbae. Trunk or body anywhere, it is Tinea corporis. And the groin and the gluteal fold is Tinea cruris. Palms is Tinea manuum. Soles is Tinea pedis. Nail is Tinea unguum. Coming to Tinea corporis, that is dermatophytosis involving the trunk and the extremities with exclusion of the palm, soles and groin area. Incubation period varies from 1 to 3 weeks. All species of dermatophytes can cause this. That is Trichophyton rubrum is the commonest, followed by Trichophyton mentagrophytes and Microsporum canis. In India, Trichophyton rubrum is the most common etiological agent. It presents as erythematous annular lesion, centrifugally spreading from point of skin invasion with central clearing. Morphological variants will be arcuate, circinate and oval. Clinical variants will be Tinea profunda, mycoses granuloma and Tinea imbricata. This is the clinical picture of Tinea corporis, wherein you can see the annular erythematous patch with scaling at the periphery. The second picture is hyperpigmented patches with eczematization. It's seen in case of recalcitrant Tinea corporis. What are the differential diagnoses you have to keep in mind when you see such cases? First one is nummular eczema. Nummular eczema usually present as discoid lesion. You will not get to see any annularity and there will not be any scaling. Petalloid type of seborrheic dermatitis, as the name suggests, it will be on the trunk, that is upper chest and back, covered with yellowish greasy scales. Whereas Pityriasis rosea, again the trunk is involved, but the distribution will be in a Christmas tree pattern on the back. Parasoriasis, erythema annulare, subcutaneous lupus erythematosus, granuloma annulare, annular psoriasis are the other differential diagnoses have to be kept in mind. Coming to Tinea cruris, this is the dermatophyte infection of the inguinal region, that is groin region and on the gluteal area. It also presents as multiple erythematous patches, pruritus in fold between the scrotum and the inner thighs. It characteristically has sharply demarcated with raised erythematous scaly advancing borders that may contain pustules or vesicles. This is the case of Tinea manuum, wherein the tinea infection of the palms and the interdigital space. The reason for different clinical picture is here there is lack of sebaceous gland on the palm, and also on the hands there is an extra layer called stratum lucidum. So it presents little different than the rest of the area. There are two varieties, that is non-inflammatory and inflammatory. Non-inflammatory is it presents as dry, scaly, mildly itchy lesion as you see on the picture. Inflammatory lesions are vesicular and itchy. Tinea faciei is erythematous patches on the face. Tinea faciei presents as erythematous patches on the face. This also presents as annular or succinate lesion studded with pustules at the border. You can see the faint border on the neck. Complaints will be itching, burning, and exacerbation of symptoms after sun exposure, always associated with tinea of the other parts. Once the patient scratches and touches elsewhere, it tends to spread by contact. It's often seen in immunocompromised adults. Dermatophytosis of the beard area of the face and neck is called as Tinea barbae, is highly inflammatory pustular folliculitis caused by zoophilic fungus. Hairs of the beard area or mustache are surrounded by inflammatory papillopustules, usually with oozing, crusting, easily pluckable. Complications can go in for abscess, sinus tract development, bacterial superinfections, chirion-like swellings, and scarring alopecia. Differential diagnoses you should keep in mind are mycoses barbae, acne vulgaris, and pseudofolliculitis. This is the picture showing Tinea barbae. Here you can see multiple follicle-oriented pustules on the beard area. Tinea capitis, this is, as the name suggests, is the infection of the scalp and the hair. Commonest fungal infection seen in children below puberty, caused by dermatophytosis, microsporum, trichophyton. Epidermophyton is generally not isolated from the hair. In North America, it is Trichophyton tonsidens most common, while in Europe it is Microsporum canis is the most commonest agent. It has two types, inflammatory and non-inflammatory. Non-inflammatory or grey patch type and black dot type. Inflammatory are the favus and chirion. Depending on the invasion, it is again subdivided. Endothrix, wherein the infection of the fungi will be within the hair shaft. Example, Trichophyton tonsidens, Trichophyton violaceum. Ectothrix is through the fragmented hyphae outside the hair shaft. Okay, favus is hyphae and air spaces within the hair shaft and a bluish white fluorescence on Wood's lamp. Grey patch type a non-inflammatory type of Tinea capitis. It's a pattern, ectothrix pattern of invasion. Patches of partial hair loss, often circular in shape. They'll have multiple broken hairs that are dull, grey, lusterless due to the overcoating of arthrospores. It causes epidemics in school. Etiological agent will be Microsporum ordini. It will be mostly asymptomatic, complaining of mild itching. Mul- Multiple grey patches will be seen on the scalp with scaling and broken hairs at the periphery. Black dot Tinea capitis. It is endothrix pattern of invasion wherein hair shaft is brittle, breaks at the level of the scalp, and the remnant of the hair left behind the infected follicle appears as a black dot on the clinical examination. It will present with diffuse scaling with minimal hair loss. Affected areas of hair loss are characteristically multiple and polygonal in outline with distinct finger-like margins. Commonly, they spare some hair within the areas of involvement. This is a picture wherein those black dots are nothing but the broken hair left on the scalp. Chirion, it is mostly due to the infection of Trichophyton verrucosum or Trichophyton mentagrophytes. It's an inflamed, boggy, indurated, tender swelling that is studded with broken or unbroken hairs, vesicles, and pustules. Sinus formation and thick crusting with matting of the adjacent hair. Lymphadenopathy and secondary bacterial infection are also noted. Since it's an inflammatory type of Tinea capitis, it heals with scarring and it can lead to autoeczematization. This is a picture of the chirion where you can see it is studded with pustules and a boggy swelling. It will invariably end up having scarring alopecia. Favus. It's a yellow cup shaped crust composed of a dense mat of mycelia and epithelial debris called scutellum. That crust is called as scutellum. Scutulae enlarge and merge to form prominent yellowish crust. It is mousy in odor. Borders of the infected lesions represent the area of advancing disease and they are always polycyclic in shape. Center of the infected area gradually becomes scarred and almost devoid of hair. Later stages they progress to cicatricial alopecia. The commonest agent is Trichophyton sholni. Coming to Tinea pedis, it has multiple types. First one is mosaic type caused by Trichophyton rubrum or Epidermophyton flocosum. Diffuse hyperkeratosis, erythema, scaling and fissures on one or both plantar surfaces. Interdigital Tinea mentagrophytes var interdigital. Trichophyton mentagrophytes var interdigital. Trichophyton rubrum, Epidermophyton flocosum. Most common type, it presents as erythema, scaling, fissures, maceration in the web spaces. Pruritus is very common. Often it may extend to the dorsum and sole of the foot. Inflammatory type or vesicular type of Tinea pedis caused by Trichophyton mentagrophytes var mentagrophytes. It presents as vesicles, bullae or medial side of the foot associated with autoeczematization. There's last variant called ulcerative Tinea pedis, that is caused by Trichophyton rubrum, Trichophyton mentagrophytes, Epidermophyton flocosum. It causes exacerbation of interdigital Tinea pedis, ulcers and erosions on web spaces, secondary infections with bacteria. This is a picture of Tinea pedis. Here you can see multiple pustules, papules with a clear-cut margin involving the dorsum of the foot and also the web space. Tinea unguum, that is onychomycosis of the nail. Onychomycosis is nothing but the fungal infection of the nail. If it is caused by dermatophytes, then it is Tinea unguum. It presents as dirty, dull, dry, pitted, ridged, split, discolored, thick, uneven nails with subungual hyperkeratosis. There are multiple types: distal and lateral onychomycosis, proximal, subungual onychomycosis, white superficial onychomycosis, total dystrophic onychomycosis. This is a picture of Tinea unguum. Toenail will be more commonly affected compared to the fingernail. Men will be more commonly affected than the women, maybe due to the usage of shoes or closed footwear. Trauma is one of the predisposing factor apart from those predisposing factor which was earlier mentioned. Most common pathogen are Trichophyton rubrum, Trichophyton mentagrophytes and Epidermophyton floccosum. Treatment wise, they'll subdivided into topical treatment and systemic. Topical treatment will be an array of creams. Starts with clotrimazole cream, ketoconazole, miconazole, iconazole, ceticonazole, luliconazole, and then amorolfine. Oral drugs will be fluconazole tablet given 150 to 200 mg per week. Griseofulvin, it is 500 to 750 mg per day. Itraconazole is 200 to 400 mg per day. Terbinafine is 250 to 500 mg per day. Duration of the treatment depends on the area involved. For example, if it is Tinea corporis, the above mentioned any one of the drug has to be given for 4 to 6 weeks. In cruris it is 2 to 4 weeks. Manuum it is 1 to 4 weeks. Tinea faciei it is 4 to 6 weeks. In pedis it is 4 to 8 weeks. Tinea capitis it is 6 to 8 weeks. In case of fingernail infection, it is 24 weeks, and in case of toenail infection is 36 weeks. So the longest duration of treatment will be involved if it involves the nail plate. Coming to the last topic of the superficial fungal infection, that is Candidiasis. Causative organisms can be Candida albicans and the other ones which are mentioned in the slide. Sites of carriage can be cutaneous, gastrointestinal or vaginal. Affected sites can be mucous membrane causing oral candidiasis, vulval candidiasis or candidial belnoprosteitis. It can infect skin or the nails. Oral candidiasis, it presents as oral thrush, nothing but white exudates resembling the cotton cheese or pseudomembranous form. In case of chronic atrophic form, it presents as a barred patch of erythema. Whereas in chronic hyperplastic type, it presents as adherent with white plaques. Site of involvement will be immunocompetent patient. In case of immunocompetent patient, it will be seen on the cheeks, gums and palate. Whereas in immunocompromised patient, it will affect tongue with extension to the pharynx, esophagus, and even ulcerative lesions may occur. Angular cheilitis, nothing but fissures at the angles of the mouth. Vulvovaginitis, it presents as itching and burning sensation with thick, creamy, white vaginal discharge. Belnoprosteitis, usually seen in men, which if they have a history of diabetes, it is more so common. Clinically presents as tiny papules on the glans penis following intercourse, and then it may involve as white pustules or vesicles and rupture. Radial fissures on glans penis in diabetics, vulvovaginitis in conjugal partner. This is the oral candidiasis picture where you can see that pseudomembranous form. These white precipitate are nothing but curdy white precipitate or cotton cheese pattern. Flexural candidiasis, so otherwise called as intertrigo, it is due to the retention of the moisture, increased temperature leading to maceration in the folds, in turn causing the growth of candida in these intertriginous area. Napkin rash presents as pustules with irregular borders. More important is they'll have satellite lesion. That is how you differentiate between diaper dermatitis and flexural candidiasis. Candidiasis of the nail, it can be chronic paronychia, clinically presents as a swelling of the nail fold with pain and discharge of pus. It will be chronic and recurrent with superadded bacterial infection. Onychomycosis is due to destruction of the nail plate. Treatment wise, first you have to treat all the predisposing factors which was mentioned earlier. Along with that, you can start them on topical medications like clotrimazole, meconazole, ketoconazole, or depending on the intensity, you can start the oral medicines ketoconazole 200 mg for 1 to 2 weeks, or itraconazole 100 to 200 mg for 2 to 3 weeks, and fluconazole 150 mg for 1 week. Thank you.